फोन आ रहा है.
Can you call her? Priya, can you call her? Are any students from Kajat Medical College here, NYT? Dr. NYT College? Great.
Ma'am, Dr. Snehal is not picking up the call. We'll start anyway. Maybe she'll join in between. Super sir, shall we start?
Okay. Dr. Revati, you can start. What?
Please start.
Yeah. Shall I start?
Yes, yes.
Okay, ma'am. Okay. So my patient is a 46-year-old female housewife residing in Chembur. She came with the chief complaint of swelling front of neck since 22 years. She noticed a swelling in the front of neck 22 years ago. Swelling was insidious in onset, started as a small swelling and gradually progressed to the current size.
46 years chief complaint. Okay, fine.
Sorry, ma'am.
Your slides are
We'll
not
continue
moving.
then.
Yeah,
Yeah,
continue.
the slides are not moving. Yeah. You're not up.
Is it moving
here.
now?
Yeah, now it is. Fine. Continue.
Okay, ma'am. There may be a lag. Okay.
It's okay. It's
She
okay, Dr.
noticed the
Revati,
swelling in the
don't-
front of neck 22 years. Okay. Shall I go forward?
Okay. 46.
Yes,
Yeah,
please
you can.
continue.
There is no history of rapid increase in the size of swelling, no history of pain associated with swelling, no history in breathing, swallowing, or hoarseness of voice or syncope. There is history of change in appetite or weight, no history to heat or cold, no history of palpitation, insomnia, anxiety. There is no history of radiation exposure to the head, no history of abdominal
Slides
distension,
are not moving.
cough.
Slides are not moving.
Dr. Revati, there's
Dr.
some
Revati,
lag in your
please.
internet connection. Can you please check your internet connection? Because even your voice is breaking in between.
Sure.
Your voice is breaking.
It's connected actually. It's okay if I speak slower or is it still breaking?
Your voice is breaking. We can't understand what you're trying to say.
Audible now?
Yes, share your slides. We'll get to know.
Is it okay now, ma'am?
Yes, better. But share your slide. We'll
Shall I
see.
read this slide again?
But we can't see your slide. You have to share your screen.
Yes. Is it okay now?
So small.
Yes.
Yeah. Okay.
Yeah,
Okay,
continue.
ma'am.
From this
Okay.
slide, you continue.
Okay, ma'am. There is no history of rapid increase in the size of swelling, no history of pain associated with the swelling, no history of difficulty in breathing, swallowing, or hoarseness of voice or syncope, no history of change in appetite or weight, no history of intolerance to heat or cold, no history of palpitations, no history of insomnia or anxiety, no history of radiation exposure to the head and neck, no history of abdominal distension or back pain, cough, breathlessness, or hemoptysis, no history of any other swelling in the neck. Shall I go ahead?
Yeah, go ahead. And then we'll come back. You complete your history
Sure,
and then
ma'am.
we'll come back.
Okay, ma'am. There is no history of any comorbidities, no history of any other surgery, no history of long time drug intake, or no history of any allergies. She takes mixed diet with iodinized salt. There is no addictions, normal bowel and bladder habits. Patient is postmenopausal since 4 years, had regular cycle with normal flow previously. She achieved menarche at the age of 13 years. She's a G3, P3, L3 with zero history of abortions. There is no history of similar illness in the family or neighborhood. Coming to the summary, my patient is a female, 46 years of age, presented with the complaint of a painless, slowly progressive swelling in front of neck with no features suggestive of compression of adjacent structures, hypo or hyperthyroidism features, and no features suggestive of malignancy.
Okay, can we come? Very good, Revati. Very, very well done. Can we come back to the first slide now? Can we just
Sure.
go to the start again? Okay. Can we?
This one?
First one. First one. Start
Yes, ma'am.
from the
This is my first
beginning.
slide. This is the first slide.
The age of start from the age of the patient and the resident of the patient.
Yes, ma'am. This is my first visible.
So, how is the age relevant in this case, in the case of a thyroid?
Ma'am, in case of young age patient, the present study of etiology and innovation, as in compared to this swelling, which is in the thyroid region, we can suspect that in the younger age and more than 50 years, malignancy can be suspected. Otherwise, in the
So it's a
physiological
bimodal presentation, right? Bimodal presentation, younger and after 50,
bimodal, yes,
right?
ma'am, bimodal. Yes, ma'am, correct, ma'am.
Okay. So is the gender important when it comes to thyroid? Is
Yes,
there
ma'am.
any
In the Ma'am, I'm not able to hear you. Is
is
the
there
question?
any relevance of the gender? Is
Yes, ma'am.
gender important? Yeah.
So, ma'am, in females during pregnancy, lactation, or during the pubertal period, there is increased growth of the thyroid hormone, thyroid in general, due to the TSH fluctuations. But in general, in a male patient, if there is a suspicious nodule, there is more chances that it may be malignant.
Okay. The goiter which you get, the thyroid enlargement you get during pregnancy or puberty or lactation is called as.
Physiological goiter, ma'am.
Okay, very good. Okay. How is the resident important in a case of thyroid?
Yes, ma'am.
Presuming there is
Uh,
thyroid swelling.
Yes, ma'am. So, in cases of endemic areas where there is iodine deficiency, the cases might be iodine deficient goiter in general. So, we ask the residents just to know whether the patient is coming from an endemic zone.
Okay. Well, which are the endemic zone in Maharashtra or in India for that matter?
I'm talking about India, there is this Himalayan belt, which is commonly known as the
Right?
endemic area. In Maharashtra, there is a district near Pune. Um, uh, I can't remember the exact name, ma'am.
So you have to read it up. It's not Pune. Not Pune, okay? Fine, go ahead.
But near Pune, there was something from yeah.
Okay, now tell me the difference between endemic, epidemic, and sporadic.
Ma'am,
If you don't,
endemic means something that occurs in the
are you
hello,
Googling
ma'am.
it? Revati?
No, ma'am.
If you don't
Can
know,
you see my
Priya, what's happening?
ma'am, can you hear me?
The voice breaks, but do you know what is the difference between endemic, epidemic, and sporadic? Or sporadic, endemic, epidemic.
Ma'am, endemic is something that occurs in a certain area, in the area, and sporadic does not have any relation geographical factors. And epidemic is something that occurs across the continents.
Fine, let's move. Next slide.
Yes, ma'am.
Okay, she notices swelling and swelling is insidious, started small and gradually. Next slide. What can you just justify all these things, all this negative history? Why have you taken this no history of rapid? When do you get a rapid increase in size of thyroid swelling?
Okay, ma'am. So, in case of a long-standing swelling, there can be acute episode of hemorrhage into the swelling in any of the cyst or anything, and that can lead to rapid increase. One is that. Second is any case of if there is malignancy in a long-standing thyroid swelling.
Malignancy,
If there is
there can be a hurricane type of behavior.
sorry, ma'am. If there can be,
Malignancy, which has a hurricane type of behavior, rapid increase in size of swelling. Which malignancy are we talking about?
um, ma'am.
Okay, fine.
Yeah.
There's no history of pain associated with swelling. When do you associate pain with the swelling? Where do you get pain in the swelling? Thyroid swelling.
Ma'am, in case of an hemorrhage into the swelling, or if it is a thyroiditis, then we can have pain in the swelling.
And what about infiltration? If there's infiltration in malignancy, can you get
Yes,
pain?
ma'am. Infiltration of the nerves also. Yes, ma'am.
What is the next? No history of difficulty in breathing and hoarseness of voice and
Ma'am,
syncope.
this I have asked for any pressure symptoms, ma'am. In case of such a large goiter, it can press on the trachea, causing difficulty in breathing. And if it is compressing the esophagus, then it will cause difficulty in swallowing. Or there can be hoarseness of voice if it involves the recurrent laryngeal nerve. And if in case of a malignancy, if it involves the carotids, then there can be syncope.
Okay. No history of change in appetite, weight, intolerance, heat, cold, no history of palpitation, insomnia, anxiety. Okay. Now
Yes,
justify
ma'am.
this. This indicates that there is no history of
Hypo or hyperthyroidism, ma'am.
no history of change in appetite and weight, no history of intolerance to heat or cold, right? So when do you get intolerance to heat? In which what are the characteristics of hyperthyroidism and what is the characteristic of hypothyroidism?
Okay, ma'am. In case of hyperthyroidism, the patient will lose weight despite normal appetite. The patient will have,
Why is so? What is the reason that the patient will have increased appetite and decrease in weight?
due to the increased basal metabolic rate. Yes, ma'am.
No history of palpitation. When do you get palpitations
In a case of
and why?
hyperthyroidism, ma'am,
Which type of
because,
hyperthyroidism will cause palpitation?
ma'am, when there is thyrotoxicosis,
Primary, secondary?
primary, ma'am. Ma'am, actually,
Primary. Is it?
no, ma'am. Secondary shows more cardiovascular symptoms.
What type of circulation do you get in hyperthyroidism? What is the circulation
Hyperdynamic
called?
circulation.
Very good. No history of insomnia, no history of radiation. What is the history of radiation has to do with thyroid swelling?
Ma'am, in history of radiation exposure to neck, certain malignancies of the thyroid are more prone, like the papillary thyroid
Like
cancer. It has more chances if the patient has history of radiation exposure.
more than papillary,
Sorry, ma'am.
more than papillary.
More than
Any other
papillary.
malignancy?
Ma'am, medullary can also develop, but it has more familial trend than radiation exposure.
What about lymphoma?
Yes, ma'am. Lymphoma can also develop.
Okay,
Hodgkin's
when do you
lymphoma.
give radiation to the head and neck? In which conditions do you think that radiation must have been given to the head and neck?
Ma'am, generally, if there is this history of any Hodgkin's lymphoma or anything, then the patient may
Hmm?
have received radiation exposure. Um, and if there was any history of any tumor in the head or anything like in those
In
cases.
benign conditions, it's obsolete. We don't talk about it.
Ma'am, very old
Radiation.
times, there used to be radiation given for tonsillitis and adenoiditis also.
Very good.
Very
Okay,
olden
now
times.
now tell me something. Is a high dose radiation causes malignancy or a low exposure of radiation causes malignancy?
Ma'am, a low exposure of radiation for more time has more increased chances of malignancy than high dose of
Why?
radiation.
Very good. Why?
Ma'am, because of when the high dose is given, even the thyroid follicles get generated
Pardon?
completely.
Your voice is. Pardon?
When, when
What happens
can
to
you hear me
those?
now?
Yeah, I can hear you
I
really
was
okay.
saying, ma'am, when the high dose of radiation is given, the thyroid follicles themselves generate, leaving behind the chance of any malignancy.
So there is follicular ablation in high dose, right? What is the latent period
Yes,
between giving radiation and development of malignancy? If it is not a
ma'am,
nuclear thing,
it's almost 10 to 20 years.
15 to 20 years,
Yes, ma'am.
but not in cases of Chernobyl and all, right? Then it is much earlier. Okay,
Yes,
no
ma'am.
history of
Even 4 years.
abdominal distension, back cough, breathlessness, hemoptysis. These are metastatic history, right?
Yes, ma'am. Metastatic history. Yes.
And do you get hemoptysis? Do you get hemoptysis? Is hemoptysis more common
No,
when
ma'am.
there is a
Breathlessness is more common. Breathlessness cough.
what is more common, Dani?
Breathlessness and hello.
Breathlessness, pleural
Yes.
effusion is more
Pleural
common.
effusion. Yes,
Yeah.
ma'am. Yeah. Hemoptysis is not that
No
common.
history of swelling in the neck. What are you indicating when you say no history of any other swelling in the neck?
Ma'am, to rule out any lymphadenopathy.
Fine. Next slide. Priya, is there no one else? No examiner? Priya? Dr. Priya? She's gone. Dr. Priya? Okay. Past history?
Okay, ma'am.
What do you want, Radha?
There's no other examiner, sir?
I don't know. She was supposed to call a few people, but I don't think they have come.
Because it's rude that I'm asking, and if someone that wants to say you want to ask, you ask. Now what to do?
No, no, no. You're okay. Go ahead. No problem, beta.
I'm, I'm okay. Okay, fine. Next,
Ma'am,
past
in the
history of no history of. What are you thinking? Why surgery is important in this case of
uh,
thyroid?
ma'am, in case of some patients, if there has been any previous surgery, any hemithyroidectomy or anything has been done, and this is a recurrence or not, to rule out that, we ask the history of any other surgery.
Okay. No history of long-term drug intake. What intake are you thinking about?
Ma'am, any antithyroid drugs like amiodarone, lithium, para-aminosalicylic acid.
So what can that precipitate?
Ma'am, they can precipitate goiter as they are antithyroid. They will negatively affect the production of the hormone.
And what about long-term iodine intake? Can it precipitate something?
Um, Ma'am, yes, thyrotoxic causes factitia.
Very good. Okay,
Yes,
next slide.
ma'am, it is a
She
personal
takes.
history.
Okay, fine. Bowel and bladder. How is the bowel in what is the significance of bowel in this case?
Ma'am, in case of hyperthyroidism, the patient may have diarrhea, and in hypothyroidism, the patient may have constipation.
Fine. Next. Patient is post-menopause. She's pretty young, right? She's only 46-year-old, right?
Yes, ma'am.
Okay. Menarche at 13. So, what is the significance of menstrual history in thyroid? And how does it present? Hyperthyroidism and hypothyroidism.
Yes, ma'am. In hyperthyroidism, there is hypomenorrhea, and in hypothyroidism, there is menorrhagia. With
What
respect
is
to
the reason? Oh, in hypothyroidism, what is the reason for oligomenorrhea?
um,
In hyperthyroidism, what goes down? TSH goes down, right?
yes, ma'am.
So yeah, same like LH and FSH.
Yes,
They say
yes, yes,
it's
ma'am.
decreased
Yes,
in thyroid. Next
yes.
slide.
There is no
Okay,
history
no
of
in the family or neighborhood. What are you? Again, diarrhea. Sorry, coming back to diarrhea. Is there
yes,
any
ma'am.
carcinoma where you get diarrhea as a symptom? Spurious diarrhea.
Especially in thyroid. I mean,
Pardon?
with respect to the thyroid malignancies.
Yes. Which thyroid malignancy can present as with diarrhea?
Um, ma'am, I'm not sure.
Medullary, right? Next. Okay, go on.
Medullary, yes, ma'am.
Family
Yes.
family history. Why is family history important in this case? What are you indicating in
Ma'am,
family history? What is family history?
yeah. Ha, ma'am. Again, to know whether the patient is from an endemic region, to know whether the people in that neighborhood have the similar diseases. Secondly, some familial cancers are there, like in
Right?
example of medullary cancers. So to rule out such history, I've asked that.
Which syndrome? Which syndrome?
Ma'am, it is related to the MEN syndrome, MEN2 syndrome.
Mentu syndrome. What are the components of Mentu syndrome?
Ma'am, there are two, MEN2A and MEN2B. In
Yeah.
MEN2A, there is medullary thyroid cancer, pheochromocytoma, and parathyroid tumors. And in MEN2B, there is again pheochromocytoma, medullary thyroid cancers, and there is marfanoid habitus.
So why is it important to rule out Men syndrome? Mentu syndrome.
Ma'am, because if it is if I am suspecting medullary cancer of the thyroid, then pheochromocytoma needs to be ruled out before going for any investigation or anything else to make the
Is there any role of prophylactic thyroidectomy in such cases?
no, ma'am. First, we have to manage the pheochromocytoma, then only go ahead for the thyroid malignancy management.
No. Is there familial history, right? So
Huh.
familial. So the next person, is there any history of prophylactic thyroidectomy if there is a strong history of Men syndrome in the family?
Yes, ma'am, there is. In fact, in men to A, prophylactic should be done less than 1 year and meant to be less than 3 years.
Very good. Excellent. Sir, Supe sir, is she going all right? I don't know. There's no one else. Next.
Okay, ma'am.
Fine, fine, Revati. You're doing very
Quite
good.
okay, beta. She's doing quite well.
Okay, thank
She's
you,
doing
sir.
very well.
Ma'am, the summary.
Okay. So complaint of painless, very progressive swelling in the neck. Anterior aspect of neck where? Anterior triangle of neck. Neck where, darling? Where?
Okay, I'm so
Neck
sorry, ma'am.
compression.
In front of neck, I have written. Okay.
Fine. Fine. Making over for the examination. Come.
Examination, yes, ma'am. Slide is visible, right?
Yeah, it's. Can you zoom a little bit? It's okay, fine. If you're happy,
Uh,
I can.
yeah, I can.
Do I have to? Okay.
Okay.
Yes.
Yeah, Radha, you can't see. She's okay actually.
Um,
Okay, sir. Okay, sir.
I will read slowly, ma'am. Uh, Patient was examined in sitting position with hands by her side in a well lit room with informed consent. Patient is cooperative and well oriented to time, place, and person. Her height is 150 centimeter, weight is 49 kg, BMI 22. She's moderately built and moderately nourished. Her facies is normal. There is no pallor, icterus, clubbing, edema, or lymphadenopathy. Normal hair luster and rest head to toe examination was normal. Coming to the vitals, her BP was 120 by 70 mm of Hg. Pulse rate was 84 beats per minute, regular with respiratory rate was
Can you?
16 per minute, and temperature.
Fine. Okay,
Yes,
pallor.
ma'am.
Do you get thyroid case? Any pathology of thyroid that can give you pallor?
Ma'am, for example,
Sometimes,
in hypothyroidism, if there is menorrhagia, the patient can have pallor
or
or malignancy also, ma'am.
anything related to pernicious anemia?
Uh, yes, ma'am.
Hypothyroidism, huh? If you don't know, it's okay, fine,
No,
not
no,
important.
am not aware. Okay.
Okay, what type of okay, PR is 84, BP is 1. Why is this blood pressure important?
Ma'am, in case of again hyperthyroidism, the patient may have high blood pressure with hyperdynamic circulation.
Hyperthyroidism, right? Hyper.
Hyperthyroidism, ma'am.
Or you
Yes.
can have a wide pulse pressure, right?
Wide pulse pressure, yes, ma'am.
Wide. Okay. Next.
Wide pulse pressure, yes.
Fine.
Coming to the
Why is
inspection,
the pulse rate important? Why is the pulse rate important?
again, ma'am, in case of hyperthyroidism, the pulse rate is important because the patient may have tachycardia, and they may also have arrhythmias, and hence we have to,
So,
the pulse rate is very,
is it important to tell us about the volume of the pulse and if there are any missed beats, or can you elaborate on those things, right? You need to elaborate on the pulse, right?
yes, ma'am.
So you can have tachycardia. What is water hammer pulse?
Ma'am, that is collapsing pulse. Because of the wide pulse pressure, when the pulse is taken in the sitting position and then the hand is raised up, there is a missed beat.
So it's a hyperdynamic circulation. Okay, fine, Nick. Good, very well
Yes,
done.
yes, ma'am.
Uh, can temperature be raised? Can you get a very high temperature in hypothyroidism or in a thyroid
In
swelling?
thyroid
And what does
storm,
that?
we can get, ma'am.
Very good, excellent. Okay, what is the
Yes, ma'am.
difference between hypothyroidism and toxicity? Toxic thyroid,
Okay, ma'am. Ma'am,
toxicosis.
thyroid is a clinical state due to the increased thyroid hormones, and in which the source of the thyroid hormones can be the thyroid gland or external also. But in hyperthyroidism, the increased thyroid hormones are due to the increased production and secretion by the thyroid gland itself.
Excellent. Next, well done.
Yes, ma'am. Thank you. On inspection, there is a single ovoid swelling of size 10 vertically, 7 horizontally, and 3 in the depth centimeter in anterior part of the neck in the thyroid region. It is extending superiorly up to 2 centimeter inferior to the mentum to sternal notch inferiorly, laterally extending 4 centimeter to the left and 3 centimeter to the right from the midline. The surface appears to be smooth and the skin of the over the swelling appears normal. There is no pulsations seen over the swelling. Swelling moves with deglutition, not with protrusion of tongue, and the lower border of swelling cannot be seen.
So lower border of the swelling cannot be seen. What is the significance that the lower border of the swelling cannot be seen?
Ma'am, it can be a retrosternal goiter also. There can be retrosternal extension of the goiter. And to
Is it
rule that,
retrosternal? There's no breathlessness, nothing there. Is it a retrosternal goiter?
ma'am, depending on the history, it does not look like that. But on inspection, the lower border was not seen.
What are the types of what are the types of presentation of retrosternal goiter?
Ma'am, the patient can present with dyspnea, um, um,
No, okay, it can be
uh,
plunging. I meant to say it can be a
okay.
plunging goiter.
Yes, ma'am. It can be a plunging goiter in which during increased intrathoracic pressure like coughing or something, the goiter comes up.
Yes. And
Uh,
swelling moves with deglutition, not with protrusion of tongue. If you wanted me to ask you what are the swellings that move with the protrusion of tongue? That's why you have put that, or you could have avoided that.
yeah, ma'am. Yeah, I was not sure whether to put it actually. Um,
Yeah, so you can avoid that. I don't know about what supercerebral. So okay, protrusion of tongue. Which are the swellings that move with protrusion of tongue?
Yeah, swelling like this is unlikely to be that I mean that thyroglossal cyst and all.
yes, sir. Yes, yes.
So
So
Yeah.
you
this
can
becomes
avoid it.
irrelevant in a swelling like this. I mean, you're trying to put it to show that that way it is, but it might create unnecessarily an distraction for discussion.
I
So,
understand, sir. Yes.
says
It
well,
could have been omitted.
could be okay, but such a large swelling unlikely to be.
Huh. Huh, sir. Okay, sir.
So which are the swelling that move with protrusion of tongue and why? Now that you have
Ma'am,
put it,
the
I'm going to ask.
ma'am, the
Sorry?
thyroglossal cyst. Hello.
What is a thyroid
Thyroglossal cyst.
cyst? And is it present in the thyroid region or a bit higher than that?
It is present higher than that, ma'am. It is generally in the sub-higher position,
When does
commonly
it
seen,
present?
or it could be ma'am. It presents in adolescent age only, generally.
And what is the age of this? 46 years, right?
Yes, ma'am. Yes, it had.
Why does
Yeah.
it move? Why does it move with protrusion of tongue?
Ma'am, the thyroglossal cyst is a tract which comes from the foramen cecum and extends into the thyroid region. So, as it is attached to the foramen cecum, it moves with the protrusion of tongue.
How do you examine for this protrusion of tongue? How should the
Ma'am,
neck be?
we
And
uh, the n- we should sit in front of the patient, put our thumb on the thyroid and ask the patient to protrude the tongue out of the mouth and see whether there is any
should the
movement.
neck be extended or it should be relaxed, flexed?
It should be relaxed and flexed, ma'am.
I I don't think so. I think it should be extended because thyroglossal tract usually is coiled. Okay.
Okay,
Swelling
ma'am.
moves with deglutition. Which are the swellings that move with deglutition?
Ma'am, any thyroid swelling, thyroglossal cyst, any lymph node which are the pretracheal or the pre-laryngeal lymph nodes, any subhyoid bursitis. These are the swellings that generally move with deglutition.
Why?
Ma'am, because they are attached to the cricoid cartilage, the larynx or the trachea, which also move with deglutition.
Okay. When will a thyroid swelling not move with deglutition?
Ma'am, if a thyroid swelling is fixed to the adjacent structures, like in case of malignancy, advanced malignancy, or in case of thyroiditis, like Riedel's thyroiditis, then in case of
Very good.
retrosternal extension, large goiter, that may
Hmm.
also not move with deglutition.
And a very big goiter might not move with
Very big, very large
deglutition.
goiter,
Next.
yes.
Fine. Next.
On palpation, ma'am, the temperature is normal. There is no tenderness over the swelling. The swelling is of size 10 by 7 by 3 centimeter. The left lobe is 10 into 4.
Sorry, when will you get a
Ma'am,
tender? When will you, in thyroid, when will you get tenderness?
ma'am, again, if there is any acute hemorrhage in the swelling,
Or what is inflammation of thyroid called as?
thyroiditis, ma'am, in case of thyroiditis, any acute suppurative
Right.
thyroiditis, yeah, yes, ma'am.
Continue.
The swelling is of size 10 by 7 by 3 centimeter. The left lobe roughly measuring 10 into 4 into 3 centimeter, and the right lobe 7 into 3 into 3 centimeter. All inspectory findings are confirmed on palpation, except the fact that the surface is nodular on palpation. There are multiple palpable nodules, average size of 1 by 1 centimeter. The margins are well defined and the consistency is firm. There are no pulsations and no thrill palpable over the swelling. The swelling is not fixed to the overlying
Margin
skin.
is very different, but how did you find out the lower margin? Because you could not feel the lower margin, right? You said the lower margin, it's a bit of retrosternal plunging type of goiter. You said I could not get under the, I cannot see the lower margin of the swelling.
Ma'am,
How did you
simply on
palpate it?
inspection, I was not able to. But when I put my finger at the lower margin and asked it to swallow, and that time when the thyroid was moving up, I was able to put
Okay.
my
Now,
mind
how do
to
you,
relieve the swelling.
how do you see for individual loops? And what is the method called?
Ma'am, to see for individual lobes, there is the Lahey's method, in which we sit
Very
in
good.
front of the patient and using the pulp of the fingers, if we have to palpate the left side, we push the right lobe to the keep our fingers on the right lobe and push it to the left side and then palpate the left side and vice versa.
And for the entirety of the gland, do you stand in front or behind the patient?
No, ma'am, the classical method is to examine the patient from behind, keep the neck slightly
Very good.
fixed, keep our thumbs on the nape of the neck and stabilize, and then palpate with the pulp of the fingers in the anterior portion.
What if the patient is fat and has a short neck?
In case of short neck, ma'am, there is a special method known as the Pizzolos method, in which we ask the patient to clasp her hands behind her head and hyperextend her head against resistance, and then we palpate, ma'am. that will make the
How do you find
thyroid.
out? When do you get a thrill? And where do you palpate for a thrill?
Ma'am, a thrill is generally seen in hyperthyroidism, and it is generally palpated over the superior lobe of the thyroid, where the superior thyroid vessels enter the thyroid.
Okay, fine. The swelling is mobile. How do you see for the fixity to the skin?
When we pinch the overlying skin, and if it can be pinched up, then it is not fixed to the overlying skin.
In which benign condition will the swelling be immobile and will not move in any direction?
Um,
Woody thyroid.
Woody thyroid, ma'am, yes. Riddle thyroiditis, yes.
Next. Did you see for any other swelling for the lymph nodes? Did you palpate for any other similar swelling in the neck?
Yes, ma'am. The next, the palpation is not completed.
Okay, sorry. I'm sorry.
Yes.
Okay, go on.
No. Again, I've written that line that the swelling moves with deglutition, but not with protrusion of tongue. Trachea is shifted to right, but the coccus sign is negative, and the carotid pulse is normally felt on the right side, but displaced laterally on the left side, and no cervical lymph
How
nodes are palpable.
are palpable? No cervical lymph.
No
Trachea is
cervical lymph
shifted to
nodes.
the right. Palpate for the trachea.
Ma'am, using the three finger method, the trail sign, we put the index finger and the ring finger on the sternoclavicular joint, and then we palpate with the middle finger for the trachea. Otherwise, we can
Very.
also use auscultation.
What is coccus sign is negative?
Ma'am, coccus sign is used to see whether the thyroid is compressing on the trachea, in which we put pressure on the bilateral lateral lobes of the thyroid and see if stridor can be elicited, which means that the patient has significant tracheal compression, and there might be complications post-op.
What is carotid pulse is normally felt, and when is the carotid pulse not felt? And what is that sign called, right?
Ma'am, it is called as Berry's sign. And in case of infiltration of the malignancy of thyroid,
What is negative? What is positive and what is negative sign?
ma'am, positive Berry's sign is that the carotid pulse is not palpable. And it is in cases where the malignancy has infiltrated into the carotid sheath, and hence the carotid pulse is not palpable. Berry's sign negative means that the carotid pulse is palpable.
Okay, fine. Anything about sternocleidomastoid? Would you like to say anything about that?
Ma'am, the sternocleidomastoid is in the normal position on the right side, but has been displaced laterally on the left side. Although, yeah, yes, ma'am, that's it.
What is any other? Okay, are we over with the palpation, or we still have some palpation left?
No, ma'am, that's it.
That's it. What is Pemberton sign? Now that
Ma'am,
you have
Pemberton
read to
sign is,
sternal,
yes, ma'am. Pemberton sign is done to look for retrosternal extension of the goiter, in which we ask the patient to raise both the hands over the head. I mean, uh, by the um, by the ear, she has to touch the hands and raise them, and keep that so for 3 to 5 minutes. And we have to watch for any signs of thoracic inlet compression, as in there can be flushing of the face. She may develop dyspnea. There might be um, engorged neck veins. These are signs that there is retrosternal extension of the goiter.
what's Kabat trachea? Very good. You're answering very well. What's Kabat trachea?
Uh, Ma'am, scabbard trachea is when the goiter has been compressing on the trachea for a long time, and hence the cricoid cartilages are weakened, and the patient may have chances of tracheomalacia post-op. I mean, the patient may have
On what?
tracheomalacia, and hence,
Is it a clinical examination, or is it some investigation, or is it a radiological sign?
ma'am, I think it's a radiological sign.
I think nahi, it is, right? How will you see for
I'm not,
tracheomalacia?
I'm not, yeah.
Why do we need to palpate the trachea? For what?
Uh, Ma'am, to see whether it is in the right
Only
position or it has shifted.
why? Then you're going to treat it, right? For
Yes,
intubation,
ma'am.
right? You will need.
Ma'am,
Okay,
but
fine.
post-op, when the patient is extubated, there can be sudden collapse of the trachea in case of scabbard trachea. and hence the patient needs to be firstly she needs to be counseled regarding
Okay,
the
okay.
chances.
Fine, I got it. Now next slide.
Yes,
Next
ma'am.
slide. Let's go to next.
Ma'am, and
Percussion.
percussion, there is no sternal dullness. Yes, ma'am. No
When do you get
sternal
a
dullness
sternal
on
dullness?
percussion
When do you get a
in case
sternal
of retrosternal goiter,
dullness?
ma'am.
What is the
In
most
case
common
of
differential
retrosternal,
diagnosis? Most common differential diagnosis of retrosternal goiter.
uh, uh, mediastinal lymph node, ma'am.
Differential diagnosis of a retrosternal goiter is asthma. Next. No bruit heard over the superior
Okay.
pole of the thyroid. Next.
Yes,
Fine.
ma'am. On systemic examination, in the respiratory system, there are normal vesicular breath sounds bilaterally. On the cardiovascular system, S1, S2 is heard. There is no murmur. Per abdomen, it is soft, non-tender, no organomegaly, and normal bowel sounds are heard. In the central nervous system, there is no focal neurological deficit, and there are no toxic signs which are seen.
What? Okay, respiratory. What are you expecting? Is there any respiratory changes you can get in malignancy, right? Or retrosternal, right?
Yes,
Cardiovascular system is involved in primary or secondary
yes, ma'am.
hyperthyroidism.
Yes, ma'am.
Is it primary or secondary?
In secondary, ma'am, secondary.
I mean, please think about it because last time also you said primary, secondary.
No,
Is
ma'am,
it primary
secondary,
or
secondary.
secondary?
In primary, CNS is more
Okay.
commonly involved. In secondary, which happens generally in the elderly population,
What is primary hyperthyroidism?
what is?
Primary.
Ma'am, in primary hyperthyroidism, the gland is producing excessive hormones, and the symptoms are seen before the swelling arises. Actually,
What is it called? What disease?
ma'am, in Graves' disease.
Graves' disease. Very
Yes,
good.
ma'am.
So it is more likely to they are more likely to have
Yes, ma'am. They are more
CNS
likely to have
symptoms, right?
CNS symptoms. Yes.
And what about eye signs? Do you see it in primary or you see in secondary?
Uh, Ma'am, eye signs are commonly seen in primary hyperthyroidism.
What is pretibial myxedema?
Ma'am, it is the deposition of glycosaminoglycans in the pretibial region, leading to edema in the pretibial region, commonly seen in hyperthyroidism.
In commonly seen
Hyperthyroidism,
in
ma'am. Hyperthyroidism.
right. Can you
Yes.
define what is myxedema?
Um, Ma'am,
If you don't know, it's okay. Fine.
no, I don't
Just
know.
huh?
No, I don't know, ma'am.
For examination, what are you looking for?
Ma'am, I was looking for any organomegaly.
In which case, when will you get an organomegaly?
Um, Ma'am, in cases of lymphoma, there can be organomegaly.
Is it?
Hepatosplenomegaly.
You you need to know about it or whatever. Metastasis, fine. Central nervous
Yes,
system,
yes,
no
ma'am.
toxic. What are the toxic signs
Ma'am, in head-to-toe
in the male?
examination, there can be fine tremors which can be seen in the hand and also in the tongue. There can be warm and moist palms. There can be
Tremors?
toxic eye,
Tremors in the hand? Fine tremors in the hand? How
fine
do
tremors.
you how do you how do you elicit fine tremors in the hand?
We ask the patient to keep her hands outstretched with fingers apart and keep a piece of paper on the.
We demonstrate the patient, okay? We show it, we show how to do it, right? We demonstrate and make the
Yes,
patient
ma'am.
do
We
it, right?
demonstrated. Yes, ma'am. Yes, ma'am.
And
Copies. Yes. And we keep a piece of paper on the hand, outstretched hand,
where? Keep a paper where?
on the dorsal surface, ma'am.
And
I mean,
and you see for the tremors.
and we see for the tremors.
How is
It
it
has to
best
be applied,
seen?
ma'am.
How is it best seen? in good light, and then you see the
In
shadow.
a
You can
well
see the
lit
shadow.
room with in a well lit silent room with the fan switched off.
Okay, fine. And what are the other toxic signs?
Ma'am,
Moist.
coming to the yes, moist and moist palms, and then there can be predictable mesoderma. And coming to the eye signs, there are a few. There can be lid lag, which is known as the von Graffi sign. There can be inability to converge the inability of convergence, which is the Mobius sign, and there can be a Dalrymple sign in which the upper sclera is visible, and then there can be Stelvag sign, which is the staring look of the patient. And when we ask the patient to look up, there is absence of forehead wrinkling, which is called as the Geoffroy sign. Yes.
Why do you get this? Why do you get retrobulbar? What happens in the retrobulbar region in case of an eye sign, bulging of eyes?
Ma'am, there is again deposition of glycosaminoglycans in the retroorbital region, which leads to exophthalmos. And
Right.
rest of the eye
Anything,
signs are elicited because of the ma'am.
anything
Hello.
about the tongue in toxic signs?
Yes, ma'am. The tremors are seen in the outstretched hand and also in the tongue. Fine tremors
How
can be
do you
seen.
elicit? How do you elicit tremors in the tongue?
We have to ask the
Is the
patient
tongue
to open the mouth. We have to
the
ask the
mouth has
patient
to
to
be
open
open or the jaw? Reti, the mouth or the jaw?
the jaw has to be open, ma'am.
And
And we ask the patient to keep the tongue intraorally. We don't ask them to protrude it outward, or else rest the tongue on the lower lip.
okay, fine, good. Next.
Yes, ma'am. Ma'am, my patient is a female, 46 years of age, presented with complaint of a painless, slowly progressive swelling in front of neck, with no features suggestive of compression of adjacent structures, hypo or hyperthyroidism features, and no features suggestive of malignancy. Swelling moves with deglutition. It's
So
a single swelling.
you're Yeah. So
Uh,
I got it. Okay. It's toxic. It is a case of non-toxic multinodular goiter with no retrosternal extension. Now, see, there is something different you said about you can't see the lower border and all, right? Maybe you
yes,
can,
ma'am. Ma'am,
maybe you can change.
depending on the rest of the examination, as in I could palpate the lower border, and on percussion also there was no dull note. Depending on that, I can likely know sir retrosternal extension.
Fine.
Yes, ma'am.
So it's a multinodular non-toxic goiter. Next.
Ma'am, that's it.
Investigation. What would you like to do on the patient? So, patient,
Ma'am,
would you like to ask something? Sir?
No, no, no. I think
Is
sure.
it okay, sir?
Yeah, fine. I
Are
think we
we
should
going?
go on now the management because see, up to this level, Revati is an undergraduate discussion about
yes,
science
ma'am.
and all. Now, this is a time if I am going to just confirm your undergraduate skills up to this science and all. Now,
Yes,
the
sir.
next part which is going to be there is a surgical decision making
Sir,
and
yes,
management decision making. Now, this is something you should go little more methodically as a surgeon, not as an undergraduate student now. Okay.
sir, yes, sir.
Okay, what would you like to do on this patient?
Ma'am, firstly, I would like to get a, TSH assessment, and secondly, I would like to get a ultrasonography of this patient.
Ultrasonography of the patient. Um, only TSH,
Ultrasonography
no
of the neck.
TFT,
Ma'am,
full
in case the
thyroid.
TSH is, in case the T, yes, ma'am,
Yeah, in case the TSH is normal
deranged only,
or
in case it is deranged, then only there is any reason to check for the T3 or the T4. Otherwise, we can manage with the TSH itself.
what about, okay, ultrasonography. What are you expecting in ultrasonography?
Ma'am, now that I'm suspecting a multinodular goiter, I want to see the if any of the nodules are suspicious for malignancy.
What are the signs on ultrasonography that will give you, that will make you, lead
Yes,
you
ma'am.
to suspicion?
Yes, ma'am. Ma'am, if there is more solid component in the swelling, if it is more hypoechoic and the nodule is taller than wider, and there are
Very,
microcalcifications or irregular borders, these are the signs on sonography which suggest that it could be malignancy.
very good. Fine. Next, what else would you like to do on the patient?
Okay, ma'am. If there are any nodules which are suspicious for malignancy, I would like to get a FNAC of those nodules.
What is triple assessment?
Ma'am, triple assessment is usually done in breast. In thyroid, we call it as quadruple assessment, and which involves the clinical examination and the pathological investigations like TFT, the sorry, the biochemical investigation like TFT, the pathological investigation like USG and FNAC.
Okay. How do you see for the vascularity, increased vascularity in case? Is increased vascularity a sign of malignancy?
Yes, ma'am. Peripheral increased vascularity it can be considered a sign of malignancy.
How do you see for the increased vascularity?
Ma'am, it can be seen on ultrasonography.
How? Or Doppler, right?
Doppler, yes, ma'am, Doppler.
So even a toxic nodule will give you increased vascularity. What is the difference between the malignant increased vascularity and a toxic nodule?
Ma'am, in malignancy, generally the vascularity is increased peripherally, whereas in cases of a toxic nodule, throughout the nodule, the vascularity will be increased.
Fine. Next, what would you like to do on the patient?
Ma'am, I'll await
Next,
the reports of the above investigations. If the FNAC is suggestive of any malignancy, uh, in my case, even if it is not malignant, I would like to go for further investigation and then plan operation for the patient.
there are multiple nodules. Where will
Yes,
you take the FNAC from?
ma'am, the nodule which is most likely to be suspicious, depending on the thyroid's grading of the nodule.
What is the grading? Can you can you
Yes,
elaborate on the grading?
yes, ma'am. The thyroid's grading is five grades are there. Zero is benign. One is no suspicion of malignancy. Two is mildly suspicious for malignancy. Three is moderately suspicious, and four is highly suspicious of malignancy. One, two, three, four, five. Sorry. And
Any
in this,
histopath you know of?
um, ma'am, if there is peripheral,
It's okay, fine. If you don't
yeah,
know, you read
yeah,
about it.
yeah,
Okay. What else? So what is your finding here? Your patient has multinodular benign goiter, right?
yes, ma'am.
Any other investigation would you like to do?
Yes, ma'am. I would also like to do the X-ray neck of the patient to see the deviation of the
Why?
trachea, and
Why?
I would,
Why would you like to do
ma'am,
the why would you like to see the
to see the
trachea?
position of the trachea, ma'am,
Why? That's what
and the
why?
retrocessional.
Why?
Okay, okay. Uh,
Why would you like
ma'am,
you're
so
going
to
to
confirm
intubate
that there is a
yeah, right? You're going to intubate the patient. So you
yes,
need to
ma'am.
see in case you're going to operate the patient,
Yes,
right?
ma'am. Yes, ma'am.
Then what else? And what about other
To
investigations?
confirm the retrosternal extension or no, I would like to do a CT chest and neck for this particular patient.
Okay.
And
When will you do
then I'll do
when
the
do you do and
when do
then
you do
continue? Sorry.
huh.
Continue
And
whatever you say.
after this I will work up the patient for PSC fitness, ma'am, for surgery. And I would like to do surgery in this case because the trachea is looking to be shifted. That means there is compressive features which are start I mean the patient may develop compressive features, and also she has a chronic history of this swelling, and a multinodular goiter has the chances of developing into malignancy also. So I would like to offer her total thyroidectomy in this case, ma'am.
Haven't you
So
left
for
out
the
one very
PSC one,
important?
yes, ma'am, indirect video laryngoscopy we would like to do to confirm the
Why would
position
you
of
like
the
to do?
ma'am.
Why would you like to do an indirect?
Ma'am, it is done
Ideal.
preoperatively to document that both the vocal cords are normal in position or some paralysis is there preoperatively itself. It is more of a medical legal
How many percent of
thing.
is there any percentage where you get a idiopathic this palsy of the vocal cord of recur? In any, do you have some few percentage of people have this
I am not sure of how much percentage.
Tanya, Revati,
documented?
hello.
Yes, sir.
You
Yes,
said
sir.
you will do total thyroidectomy, no, both sides. I
Yes,
mean,
sir.
why actually? She is a non-toxic multinodular goiter with no malignancy, both lobes involved. You don't want to keep some part of the thyroid. Why
No, sir.
thyroidectomy?
So, in case that some nodules are left behind and they develop malignancy in the future, the second surgery is more difficult. Hence, rather do total thyroidectomy. And nowadays, either hemi or total is done. Earlier, which we used to do, subtotal and near total is not practiced nowadays.
Now, subtotal is not practiced now. I agree with you.
Yes, sir.
Previously, what we used to do, because there was a visibility of the nerve and risk of all that was all there. But today,
Yes, sir.
total, especially for saving one parathyroid, is always done better, no? Even
Yes, sir.
total thyroidectomy, I mean, you would like to keep one part of that one strip for preserving one parathyroid is always done. So, I mean, when you answer these questions, especially in a non-toxic, non-malignant situation, we must make a mention of all this. Revati,
Okay, sir.
okay?
Yes. Yes, sir. Yes, sir.
Thyroidectomy
Will do.
done for malignancy, which is there, which I understand, but if there's no
Yes,
malignancy,
yes.
in these patients where you see a large swelling, you always get a good amount of thyroid on one side, so which can be always preserved. At least one side partial.
Okay, sir.
Near total, you can do it with one side preserving. That's the whole concept of near total. I understand there's a lot of change which has
Okay,
happened
sir.
in the last 30 years where people used to do subtotal and hemi and all, but in these cases now people are trying to do near total rather than complete total. Is there a literature which says that we should do total in these cases of such kind of a benign, non-toxic, non-malignant tumors? Is there a literature evidence you are trying to quote?
No, sir.
Then why did you give such?
You must find out because most of the people, sir, they are saying total thyroidectomy nowadays.
I mean, have you read any new reference which I don't know because I don't track of thyroid, but you should really tell me because my opinion was कि we can get away with near total in this case one sided with one parathyroid saved and all could be easily possible in this case. There is no need to really go and do all this. Okay,
Yes, sir. I will find out, sir.
okay.
Yes.
Okay, so uh, so can I ask her something? Supposing it's a malignant nodule, right? Why would you
Yes,
like
ma'am.
to do sonography of the abdomen?
Ma'am, to rule out any metastasis.
Metastasis one and second, Mets where?
Um,
Mets and non when it is non-metastatic, where? In which carcinoma would you like to do a sonography? Because it's a syndrome, it's a part of a syndrome, right?
yes, ma'am. Medullary thyroid carcinoma.
Right. So you do a sonography to rule out?
Yes, ma'am.
To rule out
Pheochromocytoma.
what? Yeah. So what would you like to see on that? Adrenals, right?
Yes, ma'am. Adrenals. Yes, ma'am.
Fine. Uh, so Pesa, would you like to ask something? Or we are running out of the time. Okay, we are. Sir, what are the complications of thyroid surgery? Total thyroidectomy.
Ma'am, the most common complication is hemorrhage. Then there can be injury to the recurrent laryngeal nerve.
So can we say intro, post-op?
Yes, ma'am. Then can be uncontrollable hemorrhage. There can be injury to the recurrent laryngeal nerve, and but they are not present generally post-op, intra. And the post-op, we can see the recurrent laryngeal nerve injury or the hypoparathyroidism or flap necrosis.
So,
Okay.
Dr.
So what
Jyoti,
do you
whenever
post
you're
of?
talking about complications, even post-op, as ma'am is saying, you are supposed to say early post-op, late post-op.
Yes, ma'am.
Hi
Okay.
Priya, where were
Hi,
you?
ma'am. I'm here only, ma'am.
I've been, I've been driving this seat for a long time. Okay. Yeah, answer Priya, answer
Continue.
her. You have done very well, Revati, answer.
Yes, ma'am. The early post-op complication is generally hemorrhage, and the
So, what do you keep in at the bedside of the patient? This is a UG. Again, I
tracheostomy
will say
kit,
this is
ma'am.
UG question.
Tracheostomy
Huh?
kit.
Pardon?
Tracheostomy kit, ma'am. Tracheostomy kit, ma'am.
A bell and a suture removal. What do
Yes, ma'am.
you, supposing there is a hematoma under the flap
Hmm.
or below the suture line, what do you do?
Ma'am, if I see that the size is expanding and the patient is having any breathlessness, I will suspect hematoma. And the first thing that we do is open the skin sutures and the strap muscle sutures, and then keep compression and shift the patient to OT for further exploration under anesthesia.
What is more likely to bleed? What is bleeding? What is more likely to bleed?
Ma'am, any ligature which has slipped,
Any?
the ligature which has slipped
Most probably?
uh,
Okay.
from the middle
Fine.
thyroid
What is
vein.
the blood supply of thyroid? What is the blood supply of thyroid?
Ma'am, the arterial supply, the blood supply is from two arteries mainly, the superior thyroid and the inferior thyroid artery. And the venous
Yeah, what is the
drainage is from the superior middle.
what is the fraction? Three-fourth, one-fourth, what is it?
Ma'am,
Superior
80% of the blood is supplied by the 80% of the blood is supplied by the inferior thyroid artery and 20% by the superior thyroid artery.
fine. Fine. Next, what is the other complication?
Uh,
Okay. Lately you do an indirect laryngoscopy, and would you like to judge the speech of the patient? Would you like to do some audiology before you take up the patient? Lately, like I think this has come in the recent voice
ma'am,
modulation. Would you like to check for the? Would you like to comment on that, or you wouldn't?
ma'am, we have not been following that in our hospital, so I'm not aware of that.
Yeah, but I think read it up because just read it up or just hear some clinics because they aren't including this voice
Okay,
assessment.
I'll look into it, ma'am. Yes.
So change in the voice can come because of your recurrent laryngeal and something else. Anything else?
Ma'am, it can the patient can have a mild hoarseness or irritation in the throat because of the intubation also, or there
And
can be change in the pitch if the external branch of the superior laryngeal nerve has been injured.
good. And can cutting of the strap muscle give you some sort of change in the voice?
I'm not aware, ma'am.
Anyway, if you don't know, so what are the injuries to the recurrent laryngeal nerve? Can you just end this thing by saying and what is a dangerous type of injury?
Ma'am, if it's a unilateral recurrent laryngeal nerve injury, there will be hoarseness of voice. But if it is bilateral, the vocal cords come to lie in the paramedian position, and the patient may have sudden onset dyspnea and breathing difficulty, for which tracheostomy has to be done.
What is that
Emergency
position
tracheostomy.
called? What is the position called?
Uh,
Cadaveric position. Right?
cadaveric position, yes, ma'am.
Okay. Uh, okay. So
It's okay.
anything else?
Anybody else wants to ask any questions or queries to us or Revti? Any questions? I think they're welcome. But I think Revti, very nicely done. I must tell you, you have answered all the questions very quickly, except for one or two. But most of the questions were very well answered. I really
Thank you, sir.
appreciate your thinking also. See, about this subtotal and hemi and all, no, we should really understand how the history has changed. See, there was a time when people used to
Yes.
do hemi thyroidectomy or subtotal thyroidectomy. And there used to be a lot of questions in examination, like we used to ask a thumb or a finger or
Huh.
something like. But now what has happened over last few years, people's fear of damaging recurrent laryngeal nerve with precision in the surgery has improved. I mean,
Yes, sir.
their fear has gone really. People are now more precise in doing surgeries because of the loops people use or a good lighting or good understanding. Most of the people now. Uh, so the subtotal thyroidectomy, which was classically done, is now practically getting less and less. People are not doing subtotal now. So the between total
Yes,
and
sir.
near total, those who are
Yeah,
surgeons and they do total with recurrent love kind of a demonstration. Previously people used to say don't demonstrate recurrent laryngeal nerve, but now I think people do demonstrate with a
yes, sir.
proper nerve stimulator if keep in mind and you keep try to preserve all tweaks. The question is of if you are possible, you always preserve at least one or two parathyroids, because you don't want
Yes, sir.
hypocalcemia. So when you give an answer can you can give as a total thyroidectomy with
Hmm.
preservation of few parathyroids, and that can be one given. Or if it is not possible, if there's a lot of fibrosis, then near total thyroidectomy. So the answer of
Okay, sir.
could be between total as first priority and then near total as a second priority. But preservation of parathyroids is acceptable. That is what you
Have
should.
to mention.
So this you
My
should.
last
Yes, sir.
two questions.
So the
My last two questions. Sir,
Yes,
can I
ma'am.
ask? Sorry, sir. Continue, sir.
I
I'm interrupting, sir.
read about references about this. Yes, go ahead, Radha. You can ask.
Last two questions, Eti, you have done pretty well. You have done very good. I was not that confident as at your age, right? And you have done very well. Okay. Define
Thank you.
solitary thyroid nodule.
Ma'am, solitary thyroid nodule is a single palpable nodule in the thyroid gland, which is autonomously functioning, and the rest of the gland is not palpable.
It's a discrete
It
nodule
is a
in
single swelling,
otherwise an impalpable gland,
otherwise normal gland.
right?
Yeah, yeah.
Okay. Second, one thing was that solitary thyroid nodule. Why would you want this patient to undergo surgery? It's a colloid goiter. It's a multinodular euthyroid, right? Why would you want the patient to undergo surgery?
Ma'am, because as we can see that the trachea is shifted in this case, and it may further cause compressive symptoms. And considering the chronicity of the disease, it has been 22 years. It have chances of changing into malignancy also. So, but mainly right now, why we are doing is because it can have compressive effects in the future.
Or it can become a toxic goiter, right?
It can become a toxic goiter, yes, ma'am.
Okay,
Also for the
fine.
reason of cosmesis in this case too.
Yeah, cosmos is right. Um, Anything else, Priya? Would you like to ask her anything else? I wanted to ask her something. I forgot.
Is a good indication beta for surgery.
Yes, sir.
And then the risk of malignancy and thyrotoxicosis. But if the trachea is shifted, I think you can easily justify your surgery. No problem about it.
Yeah.
Yes.
One very basic
Okay.
question I'd like to ask, last thing mostly. See, suppose you operated this patient tomorrow morning and you go for rounds in the evening to see the patient. So, what all things would you notice in the patient overall, head to toe? And
Okay, ma'am.
tell me based on the specific points, no vague answers.
Okay, ma'am. Ma'am, firstly, I would like to check the pulse of the patient and see the how the patient is, like if she's looking toxic or anxious or she's fine initially. And after that, I would like to see the operative side, whether it is any expanding in size, patient has any breathing difficulty, anything like that.
Go
How
on.
do you differentiate between a parathyroid gland and fat?
Ma'am, intra-op in the OT, we can try to immerse it in normal saline, and the fats generally floats, but the
Yes. So you just have
yeah,
to say fat floats,
fat floats.
right? That's
Yeah,
the
and
between
the
parathyroid
parathyroid
and fat.
seems, yes.
Okay. See, if you have a recurrent, what type of injury is can that be a permanent injury to the recurrent laryngeal, or it can just be a praxia? You know what's
Ma'am,
apraxia?
it can be a praxia, and we give
Yeah,
steroid trial for that. And
very
if it
good.
has to regenerate, it will generally regenerate between within 6 months or 6 to 18
You know
months.
the
Beyond
different
18 months,
you know the different grades. You know the different grades of injury? One's apraxia. Then
um, ma'am, I don't remember it exactly.
fine. I think so. We can call it a day. Sir,
Yeah, yeah,
Professor
yeah.
Priya,
Sure, we can
I
call.
think she's not completely answered my question. There are two, three more points that you'd like to see in a patient, post-operative patient.
Priya wanted to see the dressing, which is very tight. You'll release.
That is okay. What
You
else? Do you keep a drain? Would you like to see what is
Uh,
the content? How much is
yes,
it in the
ma'am.
drain? What
Yes, ma'am.
else?
Yes.
One more most important point that I want you to answer. जिसके पीछे ये पूरा question पूछा है.
Uh,
We've done. मतलब
Ma'am,
assuming
or
we've
to
done.
rule out
Assuming.
hypocalcemia,
Hmm.
to rule
Then
out
what do you?
hypocalcemia, whether there is any carpopedal spasm,
So two tests. You
or
need
there
to
is
know the name and
numbness
how
or
to
perioral
elicit.
tingling.
You need to explain, name both the tests and explain how they are done. That can be your last question
Ma'am,
for
one
today.
is the Chopstick sign, in which
Hmm.
we tap on the facial nerve area, which is in front of the uh, earlobe, and then
Famous.
if the, yeah there can
Hmm.
be twitching of the facial muscles. That is the
Hmm.
first sign. uh, then there is a Trozu sign, in which we put a BP cuff around the bicep area, and we inflate it up to 200 of Hg. And in case of hypocalcemia, there will be carpopedal spasm. There will be yeah.
So you don't inflate it up to 200 of Hg. You first take the normal BP.
Yeah,
You raise it 20 of Hg
more
more
than
than
the
the systolic
systolic
BP.
BP. Yes,
We
ma'am.
don't want to cause
Yes,
ischemia of the hand.
yes, ma'am.
Then what will happen?
how do you correct hypocalcemia?
Ma'am,
How
by
do you
How
IV
do you
connect and
give?
when
calcium.
do you connect? What are how and when do you correct? What are the indications?
Then, if there are clinical signs or symptoms, or the serum calcium is less than 8 gram per dl, and we give IV calcium gluconate.
How do you correct it?
By giving IV calcium gluconate, ma'am, it is
How do you
given
give it?
10 ml
What
in
is the amount?
100 ml D5 very slowly.
Is it? Priya, is it? Over how many minutes?
Very
It's a
slowly
rule
means
of 10.
to define the time, na? You cannot tell sister give very slowly.
Wow.
It's 10. It's 10, 10, 10. What is it?
Hmm.
Over how many minutes?
Ma'am, over 10
It's
minutes.
a practical.
It's over 10
How
minutes. It
many?
is given.
How many minutes?
Over 10.
Okay, fine.
I think
Okay, fine. One more question. In drug administration, how, supposing a patient says that I'm on a drug which is related to thyroid. So, how do we know in the history whether she's taking drugs for hypothyroidism or anti-thyroid drug?
We
What
have
will
to
she
ask
say?
when she takes the drug and whether on empty stomach, because
That's
there
all?
is.
That's all?
And uh, and how many times she takes it.
Very good. So, how many times? Which is taken multiple times?
Ma'am, propyl thiouracil, or anti-thyroid drugs generally.
Very good. Priya, sir, sir, Priya, I'm done. I think
Yes,
I'm
sir.
done.
So,
Well,
Suru
well
sir,
done,
you can
Revati.
conclude for today.
no, no. I think that's all I wanted to say. I think thank you, Radha, for holding the fort and batting the whole team. I must really tell you, you did alone. But Revati, I think your
Thank you.
understanding is very good, and you really answered all questions. I think few of the questions where you did not know, you directly said, "I don't know," which is the best way to do in examination, even in examination, rather than spending too much of time on this. Your decision making was quite right. And but I think
Thank you,
when
sir.
I ask a question, you should be able to say, yes, sir, recent guidelines say this. So that I think was missing. So you could really do little more documentation support when you're answering. What is
Yes,
that?
sir.
trends, what is the current percentage, these questions which Radha asked, some of them you could not answer. So the when you say these kind of clinical understandings, you should be backed up with proper references and statistics. Otherwise, I think excellent, and I was very happy with your performance. Thank you so much.
Thank you, sir.
Good
Thank you so much,
presentation,
sir.
Jayati.
Thank you. Well done. Regards to your HOD and your teacher.
Yes,
And
sir.
best